So we're going to go ahead and turn it over to Chrisgone, who just joined, who can go ahead and give an update here about the AI work that's been going on.
Yeah, so thanks everyone for the opportunity to have this on the call. I'll be taking you through the malaria diagnostics work that we have been doing the last few months. This is a project funded by the Gates Foundation, and it's around febrile surveillance using an AI RDT reader. So essentially trying to interpret RDT results on malaria RDTs using artificial intelligence. It began December 2024. Was to be a 23 months project to be ending September this year. Happening both in Kenya and Uganda. So 4 counties in Kenya, 4 districts in Uganda. Of course, the overall aim here is to strengthen community case management for febrile illness. It's a multi-partner project. So we have the Ministries of Health in Kenya, Uganda. We have our partner in the AI, on the AI arm of the study, that's Audere, and of course, MEDIC, and supported by our implementing partners. So next. So if I was to summarize the problem statement, is picture a test result that is on an RDT. So a malaria test has been done. There is a result on the RDT, and this is supposed to be captured in a system like we do with ICHIS. A couple of things could go wrong. One is subjective interpretation, maybe because we also track commodities on in these implementations. Maybe I want to justify past use of the commodities. And so despite having done no test, I could, for example, provide results that are not in tandem with what was done. But it's also possible that I would want a positive result just because I already dispensed medication and I want to account for it. So we know that RDTs are quite widespread in their use, and that community health workers are quite central to the use of RDTs within our communities. But despite this, there are persistent data quality issues, so transcriptions. So sometimes I just intend to give you the correct result, but for some reason, some of which is as simple as a cracked phone screen that makes it difficult to choose an option based on how it's presented to the CHW. So they end up picking what is easiest after a few taps. But of course, also because of interpretation difficulties. So picture where you have a faint line, or where a test has been done late in the evening or even in the night, because if we look at the data, we see services being offered by the CHWs even into the night. So in documentation, it said that there is an overestimation of test positivity rate in community testing. And so we see here an opportunity for either quality assurance with AI, just to tell us exactly what is happening out there, so that we don't have one line of results only from the community health worker, but also to support the community health workers, sort of in a training approach where they keep reviewing results, checking difference with an AI tool, and being better in terms of interpretation into the future. Next. So in the research study, we have, of course, the overall goal of reviewing how integration would look like of an AI tool within ICHIS, but also overall improvement in terms of malaria diagnostic, surveillance, and treatment at the community level. A couple of objectives, but all of them around diagnostic accuracy and how to improve that. The impacts of introducing AI into a workflow. So here it's saying that we look at, say, the number of tests that have been done in the past, and then see if introduction of tools that aids them driven by AI would, for example, change the number of tests that they do. And then, of course, for every system, at the end of the day, it's a people-driven engagement. And so we want to look at, do they find it usable? And is it something that they would be willing to adopt? And lastly, around cost effectiveness, just putting out there, is there value in this compared to the investment that would go into it? So next. So to study this, we have a study design. In the study design, we have a mixed methods evaluation. So we have a controlled randomized clinical trial, but we use both quantitative and qualitative approaches. So in terms of the quantitative data, we have the data coming in through EACHs. That is the interpretation that the AI offers as distinguished from or compared with the interpretation from the community health workers. But we also do a quantitative survey. So in the survey, we have a set of closed-ended questions that we pose to the community health workers along the study. So in Kenya, for example, this is done at the beginning. So before the introduction of the tool, sort of the baseline, we have a midline, and then we have an end line. We also do FGDs with the community health workers, where we try to surface, any usability issues, any barriers to adoption from a focus group discussion approach. But then we also have key informant interviews with the health system managers, defined here to be people who have access to the dashboards. In terms of Kenya, we are deploying this within 4 counties. With 189 CHUs, 1,880 CHWs. And these CHWs are put into 2 groups. One we call the blinded group, the second we call non-blinded group. So in the blinded group, they will be able to see the interpretation. In the blinded group, they will have only their interpretation. They will take a photo, the interpretation will be done in the background, but then they would not know what result was interpreted. That group is paired with their supervisors, who then are allowed to see those results and to try to intervene where they feel that the differences are sufficient to warrant intervention. And so for that, the conclusion from the study would be, what would you achieve with supervision in terms of improving quality? In the second arm, where they see the results, where they see the interpretations from the AI tool, their results are not shared with the community, with the supervisors. So essentially, we assume that they will have a second look, maybe a third or fourth look at the results on the RDT, and that makes them better with time. And so improvement from that arm would be attributed to use of the tool. Uganda has a different setup, the setup where the blinded and non-blinded are serialized. So you have 3 months for blinded, subsequently 3 months for the non-blinded. It's just a decision to adoption where they wanted first to try the tool. So that trial would be given within the first phase, which is blinded. And of course, for each of those setups, we have a control group that runs throughout the study. The numbers in Uganda, comparable with Kenya, 1,863 community health workers against 89 health facilities. So one other thing that perhaps would be interesting here is that we also have
Chrisgone, your audio has dropped.
Training cards. So in the deployment, what we did, we walked through those changes with training cards. And so then we would attribute their performance to self-training. And of course, then following that up with the supervision from the community health workers on one arm, and the other side from the tool. So next. So I would run us through a demo of this, maybe just to have that playing. We'll keep stopping us. So you get to the households list, get into the household, and then just pause a little. The testing happens for both under fives, and over and over fives. So in this, just carry on. So we will select a household member in this case, but then this is a subject to screening at the household level. Then get to the assessment tab. And so the entry is that someone is sick, and then subsequently that there is fever. So you would have to have fever selected, and then that would activate the fever, the assessment workflow for fevers and malaria. Maybe just posting it there. There are a couple of conditions in the workflow as it was prior to the study. So like how many days has the fever lasted? So anything beyond 7 days, they can't handle at the community level. That is subject to referral. Then we have the question whether they have medication. So in Kenya, there is a test and treat policy. So you're not going to test if you can't treat. So first ask if they have ALs. And then because we have the age already, the system determines how many tablets would be needed. And so if you have less, then you're not going to test, but only refer. So then next, then with ALs, we asked if you have an MRDT. Again, without MRDT, of course, you would never test. So you would say, yes, I have ALs, you see up there. So then do you have RDTs? Yes. And then you would specify, so this was a little expanded given the study, you would specify the type of, the brand of the MRDT that you have. So in this case, Parahit is chosen, is selected, but just keep in mind that there's another option. So the AI is multimodal. So there is a model for each of the WHO approved RDTs. And in the case that there is one that they can't identify, they go for other. That uses a foundational model, less as well performing as the others. So the CHW would then interpret the results on the test. So what you have, you see there, they would indicate what their result is. So just play that ahead. So in this case, they've chosen a negative result. And then we would kick in the study, ask if there is consent. So that is the first question from the study. With consent, then we go into taking a photo of the RDT. This was taken in very poor lighting, and just to show you how well that works. So then the result is interpreted, in this case positive, it's displayed to them, and then we believe that at that point they had said negative, they would walk back and try to see what happens. And then the rest of the workflow, looking at the other things, oral health, TB assessments, HIV assessments, all the way. Maybe in the interest of time, we could advance this to the next slide. So our progress to date in the research is we socialized this with the stakeholders in Kenya and Uganda, completed that exercise February last year. The integration from what you have seen, both at the level, at the CHT, at the platform level, and also within the customization of the different apps, Kenya, Uganda, was completed July last year. We did a UAT in both countries in August 2025, last year as well. We had the study approved by AMREF ESRC for Kenya in August 2025, but for Uganda in November 2025 as well. In Kenya, we work with IPs. So these are partners who are already in malaria case management, the four, one for each of the counties, but one of them covering 2 counties. We onboarded them in November 2025. We did an implementation launch, of course, accompanied by a baseline survey. so at the entry and the FGDs in December 2025 for Kenya, but did this in February for Uganda, who have the next update would be given by a teammate from Uganda. Next, and Dr. Medi, you're on the call.
Yes, thank you very much. Good evening. Yes, so the progress is very similar to Kenya. We did the implementation kickoff. We had the team from MEDIC support us to do the integration within CHT and the app customization. The integration is for the AI. We had the user acceptance test with the users and the supervisors, and there was some excitement to finally see AI in action. And they gave us some useful input. The study protocol was approved. We had site selection. We had the launch that was done together with the baseline survey just last month. And now what is happening is a post-deployment support and follow-up. And throughout all these steps, we have had back and forth stakeholder engagement to ensure that the districts and the national team are aware of what is happening. Thank you.
Thanks, Dr. Medi. So we can advance this next. So in terms of some key lessons learned, of course, some of which are quite recurring within the community health system, connectivity and syncing. We noted during deployment, for example, that you would have cases of community health workers who haven't synced 2 months of data. I think that gets quite frustrating because if connectivity is a limitation, then it's more frustrating as you do more work and have more data on the device. But some of which we would reinforce, like syncing guidance, like saying do this as often as you can, rather than wait for maybe end of the month. We have been facilitating them to be able to sync their data, but of course also troubleshooting in cases where that fails for some different reasons. We also have noted issues around commodity supply. I think some unintended impacts, for example, where the health system in Kenya allocates resources based on how many people visit health facilities. And so you have this tension of, do we let them come to the health facility, or do we facilitate the community health workers to see them at the community? That's some tension that came up during implementation. And of course, device and photo captures. We've had challenges, but that have been resolved across different devices. We currently have one type of device that is held by 2 community health workers where we have a challenge, but that's being investigated. Next. So in terms of some early findings, by mid-February, we've done quite a number of tests. This is 17th of February, so 3,363 tests. Apologies, I hope the noise isn't too much. So 3,363 tests. Siaya had the biggest volume of tests by then, second, followed up by Bungoma, 1,201. But just want to point out there that Bungoma had actually done their implementation mid of January. So quite some test volumes coming in from there. In terms of concordance, agreement with the tool, and we define this as where the test results are the same. It's quite very high with the community health workers, so 89% overall, but ranging between 87 to 92%. We've noted in that data, of course, this is very limited data for analysis. We have an 8-month study, so quite many months to still go. So similar performance between blinded versus unblinded arms. So no difference whether people see results or not. But then slightly higher performance for those who are trained in person. So 90% versus self-training at 88%. So 2 percentage point difference for the investment in training, something quite that you would like to see, full study results on later. We've also noted difference in consenting. So Siaya, for example, gives us 95 percent consenting rate. So the community, we asked them if they allow the photos of the RDTs to be taken, and only 5% decline in CIA, but the others a little over 24%. But again, trying to note that the county has quite a big research burden. They even insist on local approval for research studies. So that tells you probably why you have higher rate of consent in that county. And maybe next, as we sum up, is as we take the last one, maybe a colleague from one of the IPs to share their experience in 30 seconds to 1 minute. And thanks, everyone.
Thank you, everyone. Good evening, all. This is Wellington from Population Services Kenya, an IP also implementing the febrile illness surveillance studies in Kenya, in Bungoma counties to be specific. Yes, so quite some good excitement there, despite starting midway January, and we can see the numbers that we were able to push in. So very high adoption from the community health promoters, and over and above that is that most of it, the workflow is quite encouraging to the CHPs. And this is also good that even the CHPs who are trained in-app using the training cards, we see that they are actually picking that a little bit quite well. And we have very few challenges coming in. Majority of the challenges, what Dr. Chrisgone has mentioned, including to the community health policy that we have within the ground, that they're trying to advocate for more facilities are rewarded more if they have a lot of people coming into the facility, the health facility. So that connectivity is a problem, but we've been able to do advocacy to the county level, and this has helped some user acceptability, and we have commodities being given to the community health promoters. And so far, we can say, so far so good. We are doing about 85% of the CHPs having commodities, and we are also having better commodity accountability via the CHT, which is a very good thing, and is also giving confidence to the sub-county and the county team. Over to you, Chrisgone.
Any last comments, Chrisgone?
Thanks, everyone. I think that sums it up from us. Just to share one last thing we got from the community. So, one in one of the survey, in the survey, there was a question if they sometimes treat when there are negative test results. A small percentage, 3% or so, said yes. And this was said to be demand driven, like it's the communities demanding, literally saying it's not your medication. I'm sure once I have fever, as such as I do now, then I have malaria. And so as a CHP was saying that presenting the results, the interpretation from the tool to a community member who was insisting on a medication was good enough to dissuade them from going with the medication, because they felt, the community member felt like they had a third opinion, and it's from a device, and it studied with what the community health worker was telling them. So some surprise use case that came up from that. Another was even the fact that they can zoom the camera, so they can zoom the RDT on their phone to make it bigger in size, was already good enough for some people because of acuity, visual acuity issues. But thanks, and we'll share more as we wind up this time.